Rahul,
Huh.
yeah. So the continuation of lung ultrasound. We all know that last time we had a basics of lung ultrasound. Now we are continuing with lung ultrasound and other pathological conditions associated with the lung, like pneumothorax, pneumonia, and transient tachypnea of newborn, approach to respiratory distress, how to utilize ultrasound in adjusting the ventilator setting. So this will be dealt today, and today it's going to be a last class. So I request Rahul to start the session. Over to you, Rahul.
Thank you, Prashant. My slides are visible.
Yeah. Kindly put it in slideshow mode. Yeah, we can see. We can see now. Okay.
Okay. Last class we already discussed about the basics, but few of the people they message me or call me and ask like they missed that class and they just want to know about it. So I'm just going to touch it in 5 minutes, not more than 5 minutes, and then we'll go to the pathologic conditions. So just to tell, I mean, this is just a revision, like how the lung, healthy lung looks like. So you have a skin, soft tissue, pectoralis muscle, ribs, intercostal muscles, pleura, pleural space containing fluid, and lungs down. So two things are important, like one, like air and bones, they are enemy of ultrasound waves, and they're going to reflect ultrasound waves back. And these two properties we use to do lung ultrasound. So a rib is a bone, ultrasound waves will come till here and they will be reflected back, and you will see a black shadow down. That's a acoustic shadow. And the ultrasound waves, they can come through skin, soft tissue, pectoralis muscle, intercostal muscles, both parietal and visceral pleura and the pleural space, as it contains a fluid normally. So they'll reach till a pleural lung interface. Now lung contains a air. So they'll reach till the junction of a lung surface and visceral pleura. And as there's air down from here, again the ultrasound waves will go back, and what we see down is actually the artifacts, and that's what we interpret in lung ultrasound. So this we have already discussed. Linear high frequency probe. Procedure also we have discussed, like probe should be exactly perpendicular to the chest, and there should not be any fanning, angling, sweeping and all. And zones I'm going to talk about. The transducer should be facing cephal head or anteriorly, and you have to keep probe exactly perpendicular to the chest. Now scan, do at 4 areas we discussed last time. So you have a midline, you have a anterior line and posterior axial line. So this is upper anterior, lower anterior, upper basal and lower basal. Apart from that, you're going to do a scan at a flaps point. Flaps point is nothing but say in newborns, arbitrarily you draw a line at the level of nipple or just below the level of nipple and draw it, trace it back to the posterior axial line, and you put a this thing transducer over there, and that's a flaps point. Again, your orientation marker should face and cephal head. You can go a bit more posterior, so you have to do scan at 4 points on either side and flaps on either side, so at least 10 points scan. Now a normal lung, how a normal lung look like, we already discussed. It's a profile, what we call, and this A profile, what it contains a thin pleural line. I hope this video is playing and slides are synchronous. So you can see this is a thin pleural line, brightest structure, and then you get equidistant A lines, horizontal lines. These are artifacts. And you may get occasional comet tails, and there is a lung sliding. I told you last time what is a lung sliding. It's like a shimmering or ant marching. You can look at the pleural line. It appears as if it is a shimmering or ant marching. So that's a thin pleural line with lung sliding, equidistant A lines, and no or occasional B lines. That is your A profile or a normal lung, how it looks like. And on M mode, this lung sliding, it is going to look like a seashore. Last time we already discussed. Now you can see here a lung sliding is visible, and you put a M mode and you see a seashore. So you have a brightest structure pleura, ocean that is sea, which is not moving, superficial structures, and then shore that is a lung, which appears like a say grainy appearance. So that's a seashore. So just to summarize a normal lung, this image is more than enough for you to know what is a normal lung. So you have a pleural line, thin pleural line. These are the ribs, these are the superficial tissues. Then you see equidistant A lines, horizontal artifact. This is what we call it as a bat wing sign, and you put M mode across and you're going to see a seashore sign. Nothing, what it means, like motionless upper part which is formed by a skin and soft tissues, brightest structure pleura, and then motion of the lung is represented by a shore or grainy appearance, what we call it as a sand on the beach. So a normal lung or A profile, you are going to get pleural line, very important. You're going to get equidistant A lines, and you're going to get a seashore sign or sandy beach appearance on M mode. That is your normal lung or sliding, what we mean. And just to show you how the image will appear at a flaps point. So you basically have to do scan at all 4 points, the anterior 4 points and the flaps point, and see again how the cursor is put. The orientation marker is anterior, and this is how the image looks like on flaps point. This is on right side. So I hope this video is playing. So you can see the flaps point on right side. So this is how a flaps point is going to look on right side. So you have a liver, you have a upper pole of kidney, you can see a diaphragm, the bright structure, and then you can see a lung coming in with every inspiration. You can see a spine down. So this is how your normal flaps point look like. Again, you have a liver here, a kidney, you can see a spine, diaphragm and lung coming in. You can see even the pleural line, the brightest structure when during inspiration, and A lines. So just I'm putting color here for better understanding. So same image. So you can see the blue is a pleural line which is coming with the inspiration. Then you have green, these are equidistant A lines in a normal lung. You have a pink diaphragm and you have a orange spine. Now you can see here the spine, you can't see it beyond the insertion of diaphragm. This is because again you have a air in the normal lung, and that air is going to reflect back ultrasound waves, and you are not going to see anything beyond this point. So in a normal lung, you can see, you won't be able to see any spine beyond the diaphragmatic insertion, whereas in the abnormal lung you will see a spine. I'll show you later. Now with this basic of a normal lung, again to summarize, A line, lung sliding, thin pleural line, no or occasional B lines, and seashore sign. That's your normal lung and how flaps point look like. And now we'll move ahead with the abnormal lung ultrasound patterns. So as I said, lung ultrasound is a study of artifacts. So what we see is basically mirror image of the superficial structures down the pleura, but that pleura does not always work like a mirror. So whenever the fluid content of lung is going to go up, the sound waves can go inside. So they can go through fluid or a soft tissue, and you can see actually a real image, and that happens in the most of the lung diseases. So let us see one by one. So this also we covered, so I'm going a bit faster. So the first abnormal lung ultrasound pattern is a absent lung sliding, and we are going to get a absent lung sliding whenever both pleura are not in contact. So it can be pneumothorax or it can be pleural effusion, or when pleura they are stuck together. So it can be because of any inflammation. It can be pneumonia, it can be RDS, meconium aspiration or BPD. Plus, if your ultrasound waves, if they are not hitting exactly perpendicular, if you are holding your probe like this or tangentially, lung sliding will be less visible. So you will interpret as there is no lung sliding or there is minimal lung sliding. So that is a what you say, like operator dependent error. So that's why in lung ultrasound you need to have your probe exactly perpendicular to the chest. So now we have already covered this, that's why I'm going a bit faster. Now concentrate on this video. See the first part, there is a lung sliding, and you go one space above, you can see like there is no lung sliding, there is no ant marching, or there is no shimmering at pleural line. So you can appreciate lung sliding very well at pleural line. So basically parietal and visceral pleura, they should move like this on one another. There should be a sliding movement. It is not like this, it is not like this, it is like this. So you can see again there's a shimmering, and you go one space above, there is no shimmering, so it is absent lung sliding. And if you put a M mode here, I hope my videos are playing. So if you put M mode here, you can see. Now see on real image B scan, there is no lung slide visible. You put M mode and you can see like there is no seashore appearance. Your shore has disappeared. You can see it looks like barcode. So this is basically absent lung sliding in case of pneumothorax, where you will see barcode appearance on M mode. So again I am playing, concentrate on B mode. You can see you can't appreciate any lung slide at pleural line. You put M mode across and then you can get this appearance. So if you are not able to appreciate lung sliding on a B mode, just put M mode across and see whether you can see seashore appearance. If there is a lung sliding, you will see seashore. Here you see this is a sea and you can't see any shore here. Whereas in normal lung, you will see sea here and a grainy pattern here. It is not there. This looks like a barcode. So this is barcode slide in M mode. So that's a absent lung sliding. So we saw, yeah, please. Yes, so we saw first abnormal sign, that is absent lung sliding. I'm going it bit faster because we have covered these things in previous class. So next abnormal finding will be B lines. So again we saw already how B lines appear and all. All these 7 points should be there to define a B line. So it's a ring down artifact, I explained already. B lines, they'll arise from the pleural line. They will move along with pleura. Whenever there's a lung sliding, you can see the B lines moving with lung sliding. They are long and vertical. They are well defined and they'll extend distally till the edge of screen without fading. You will see them through and through from the pleural line till the edge of your ultrasound image screen. It will erase A lines and B line will be hyperechoic. It will be as echoic as pleura. So this all points should be there to define a B line. And again, B line we should distinguish from certain artifacts which we call comet tail, which can be seen in normal lung. So comet tail will be less echoic than pleural line, whereas B lines will be as echoic as pleural line. Comet tails will be ill-defined and they'll vanish shortly after pleural line, whereas B lines are well-defined and they'll go till the edge of the screen. Comet tails, they won't erase A lines, whereas B lines will erase A lines. And comet tails, they won't move with lung slide, whereas B lines, they will move with lung slide. Now, look at this video. So concentrate here. So I'll play it again. It's a small video. It is playing on its own. You can see, yeah, you can see there's a nice pleural line. Yeah. So I'm playing it again. You can see there is a nice pleural line, and you can see subtle vertical artifacts which are disappearing soon, and you can see A lines across also. So that is comet tail. Whereas now you see the next video. Yeah. So you see this video. So you can see there are lines starting from pleural line going till the edge of the screen. They are as echoic as pleural line. You can't see any A lines. They are well defined and they are moving with lung sliding. So that's your B line. So this is how you distinguish comet tails from B lines. It's very easy. Yeah. So we know how B lines appear. Now, coming to the interstitial syndrome, as I told last time, up to two B lines, if we see between two rib spaces, that is normal. If you see more than B lines between two ribs, then that is called as a lung rockets or interstitial syndrome. So up to two B lines between two ribs, it's normal. If you see more than two B lines, it's called as lung rockets. If you see three or four B lines between two ribs, it is equivalent to curly B lines. And if you see lung rockets at 4 points of the anterior chest, that is upper anterior, lower anterior, upper basal and lateral basal. If you see lung rockets, what I mean by lung rockets, if you see more than two B lines between two ribs, that is called as a pulmonary edema. Now you can see here there are so many B lines between two uh, rib shadows, 1, 2, 3, 4, 5, 6. So it's almost equivalent to curly B lines, and if you get such a finding on all four anterior areas of chest, then we can call it as a pulmonary edema. So basically, interstitial syndrome is a sonographic name, and we can see it in all newborn conditions. TTNB, RDS, meconium, BPD, everywhere you are going to see B lines. You can see it in a pulmonary edema. It can be of cardiac cause or a respiratory cause, say ARDS or acute lung injury, and you will see it in pneumonia as well. So it's a gross entity where you can see it in a multiple conditions. So whenever you see interstitial syndrome, you need to look for other signs and then make a diagnosis. Now coming to the first common pathological condition or first common cause of distress is a transient tachypnea. So how we are going to make it on lung ultrasound? So first and foremost, most important thing in transient tachypnea, there won't be any pleural line abnormality. Your pleura will be very thin and normal. Most of the times the findings will be bilateral, but it's not compulsory. At times one lung may not be affected, one lung may be affected. You will see something called as a double lung point in a mild cases. I will show you what it is. And you will see B-line pattern in a moderate cases and white lung in a severe cases. I will show you all these patterns, how they look like. Now, in mild effusions, it's a normal tendency that fluid is going to gravitate posteriorly or in lower parts. That's why you will see coalescent B lines or compact B lines in the lower part of the lung, whereas there will be air in the upper part of the lung where you will see a normal A profile. You will see A lines and pleural line, and you will see A lines and few comet tails. So this point of a junction of a normal upper lung and lower lung with a fluid, we call it as a double lung point. You are going to get it in a mild transient tachypnea. Now you can see here I'm playing this video. We did it 2 weeks back after, 2 days back after our last class in one of our patients. So you can see it's classic double lung point. It's already. So this is how the double lung point looks like. We have done it just 2 days back in one of our babies who had a mild RD. So that's your double lung point, which we will see in a mild transient tachypnea. So now, in moderate cases, you are going to see something called as a B line profile, where you will see too many B lines, but you can distinguish them. They'll be seen differently. They won't be compact. So moderate cases, you will see a B profile. You can see a lot of B lines. So basically, you will see thin pleural line, and you will see a lot of B lines. You won't be able to see any A lines. So basically, B profile means what? You will have a lot of B lines, and there will be a lung sliding present. So and there will be a normal pleura. So that is a B profile where you have a lung sliding along with B line. So that is B profile. What you will see in a moderate cases of transient tachypnea. Here again you can see in a static image lot of B lines, but you can distinguish them separately. So you will see it in a moderate cases. Whereas in severe cases, you will see a white lung total. You can see here now in video, there are so many compact B lines. So it will, static image will appear like this. It will be compact B lines. You will see totally white lung pattern. So in severe TTNB, you will see a white lung. So this is how the TTNB will appear: double lung point, B line profile, and white lung. But remember, pleura will be normal. Again, some images. See, as I told earlier, like one lung it may be less affection, one lung it may be more affection. Now this baby, this is a right side lung ultrasound where you can see a double lung point, where there is a mild TTNB. Whereas left lung you can see a B line profile where there is a moderate fluid in the lung. So you can have a different findings in both lungs. So transient tachypnea of newborn we saw. Pneumothorax also we saw last time. I'm just going to revise it quickly. Pneumothorax, if you know lung ultrasound, you can detect it within less than 1 minute. Only thing, you need to examine all areas in sequence. Most of the times pneumothorax will appear in the anterior areas, but you need to examine all areas in sequence and you need to follow this algorithm. So we'll go through this algorithm. So first thing you need to look for is a lung sliding. If you see lung sliding, 100% there is no pneumothorax. The negative predictive value of lung sliding is 100% for pneumothorax. So you put a probe, you see lung sliding, you have ruled out pneumothorax in that area. Suppose now you put a probe in anterior chest and you see that there is no lung sliding. Then you should look for B lines. Again, if you see B lines, you rule out pneumothorax. So even if there is no lung sliding and if you see B lines, it means there is a fluid in the lung and you are ruling out a pneumothorax. So if you don't have a lung sliding and there are no B lines, means obviously you have A lines in the lung. So what you have here is A lines with absent lung profile, and that's what we call it as a A dash profile. So A dash profile is you have a absent lung sliding along with A lines. So remember I told earlier, A stands for air. It doesn't distinguish between the pleural air and alveolar air. So once you see A lines, it doesn't mean that lung is normal. You need to see lung sliding along with it. If there is no lung sliding and if you see A lines, it means air is in the pleural space. So absent lung sliding along with A lines forms a A dash profile. Now, A dash profile is highly suggestive of pneumothorax, but it is not specific. So, if you see A dash profile, you need to go and search for lung point. First, we'll see how A dash profile looks like. So, this video I have played earlier. So, this is how A dash profile looks like. So, on B mode, you don't have a visible lung slide, and then you put a M mode across, and then you're going to see a barcode sign or stratosphere sign. You can see pleura, superficial structures and deeper structures all look similar. So that is a barcode sign or stratosphere sign, and this is how the absent lung sliding will look like. So absent lung sliding on M mode forms a stratosphere sign or a barcode sign. So first step is to look for lung sliding and then look for B lines, that is A dash profile. So as I told you, like now if you have a A dash profile, it is highly suggestive of pneumothorax, but it is not specific. So if you see A dash profile, you need to look for something called as a lung point, which is 100% specific. If you see lung point, it is a pneumothorax, you don't have to go ahead. So as I told you earlier, lung point basically it is a transitional zone between a normal lung and a pneumothorax. So basically, if there is a pneumothorax, pleurae are separated, and when a normal lung comes, pleurae are again going to come in contact with each other. So basically, lung point is going to form a boundary of a pneumothorax with a normal lung. And as I told, the air will accumulate anteriorly, so you need to go laterally to search for a lung point. So now you concentrate on this video properly. So now concentrate in the middle part of this video. You can see a pleural line, but you can see there is no shimmering or there is no ant marching, and you can see A lines down. There are no any P lines. So basically this is A dash profile, that is absent lung sliding and A lines. Now you look at the peripheral parts of this video, both sides, you can see there is a shimmering or ant marching movement at the pleura, and you can see some comet tails. So what you see is lung slide and comet tails. And now this point where the lung sliding appears is lung point. So here you see double lung, I mean lung point on either side, and this lung point is 100% specific of uh, pneumothorax. And now if you put a M mode at this point, see, you can see a lung point on M mode also. So this is a normal lung. You have a C and a sure, but here you have a barcode sign. So there is a pneumothorax here, whereas this is a normal lung. So this is how lung point looks like. So if you see lung point, it's 100% pneumothorax. So now you have seen lung point. If lung point is there, pneumothorax is there. But if lung point is not there, you need to look for something called as a lung pulse. I'll be showing video later. And if you see that there is a lung pulse, then it rules out pneumothorax. And if you don't see a lung pulse, then it is a pneumothorax. So uh, lung pulse is basically a transmission of cardiac activity through a motionless lung, and it is because of a movement of visceral and parietal pleura due to cardiac motion. So to appreciate lung pulse, that area of the lung is usually has to be near to the heart, and usually in B mode it is difficult to interpret, but it is very easy to interpret it on M mode. It will form something called as T lines along with pleural line. I'll show you how it is. And this transmission of cardiac activity through lung is required. So it rules out pneumothorax. I mean, if there is any air, it is not going to transmit the cardiac activity and you are not going to get lung pulse. So as I said, B mode it may be difficult to pick, but M mode it is very easy to pick. So you put a M mode across, and now you see there is a superficial structure appear as a C. You have pleura, and you can see like possibly there is no lung sliding. Lung sliding is absent because you don't see there is a shore-like pattern. It is not grainy, but whether it is a pneumothorax. So as we said, like you need to look for lung pulse. Now you concentrate and see at these arrows, you can see a in vertical lines in lung shadow. So it forms kind of T with a plural line T. So this is called as a T sign. So if you see a T sign or a lung pulse on M mode, then it rules out pneumothorax. So now you concentrate on this video. You concentrate on this video. From beginning, those who were not there earlier, for them I can tell superficial structures here. You can see the pectoralis muscle, you can see the intercostal muscles, you can see the ribs on both sides, and you have a pleura. Now see here, pleura is thin, but see there is no sliding at pleura. There is no sliding at pleura. There is no ant marching. There is no shimmering. One thing. Now you see there are A lines down. You can see A lines down. Yeah, and these are comet tails. These are not B lines. These are some kind of comet tails. These are no B lines. So you can see like this is a pleura with no lung sliding. You have no B lines. You can see equidistant A lines. So this is your A dash profile, that is absent lung sliding with A lines. And then what you need to look for, lung point. So you have a A dash profile, you have to look for lung point, but you can't see any lung point also here. I mean, there is no shimmering anywhere. So there is no lung point. It is so when you see there is no lung point, you need to look for lung pulse. Now on B mode, it is very difficult to appreciate lung pulse. There is no lung pulse here, but it is very difficult to appreciate. So what you will do, you put M mode through this. So once you put M mode through this, and this is what you'll see now. So you can see, then you have a barcode sign basically. There are no T lines. So there is no lung pulse. So if you don't see a lung point, then you search for a lung pulse. If there is no lung pulse, it is pneumothorax. So this is how you diagnose a pneumothorax on lung ultrasound. Now going to the alveolar syndrome. So alveolar syndrome is nothing but whenever your alveoli are pathologic, means either they are filled with fluid, they are collapsed, they are without any air, or they are filled, there is inflammation. So in that condition, what we call it is a alveolar syndrome. So alveolar syndrome can be consolidation or it can be collapse or atelectasis. So even in newborns, RDS is alveolar syndrome, meconium aspiration is alveolar syndrome, BPD is alveolar syndrome. So it's a group of conditions. So coming to the lung consolidation or pneumonia, how lung consolidation or pneumonia, we are going to pick it up on lung ultrasound. So usually consolidation, they are very highly fluid filled and they can reach the pleura and you can see directly with a lung ultrasound. So there are different patterns which you see in lung consolidation or pneumonia. You will see anterior consolidation, tissue-like signs, red sign, bronchograms, increased vascularity and lung pulse. Let us see them one by one. Now, anterior consolidations you can make out very easily with lung ultrasound. See superficial structures, reef shadows on both sides. You see the pleura, and down the pleura you see the consolidation. So, consolidation, anterior consolidations you can make out very easily with lung ultrasound. You can see the consolidated area and B lines down. So, this is how anterior consolidation will look like. The second sign is a tissue sign or hypertension of the lung. So normally lung is filled with air and you're going to see artifacts and you're not going to see anything like tissue in the lung actually when you do ultrasound. But with consolidation, your lung will appear like a tissue or like a lever. So this is ultrasound at a right flaps point. You can see a diaphragm, you can see a lever, and see your lung is almost looking like a lever. So that is a hypatinization of the lung, or your lung will look like a tissue. So basically normal lung, you are not going to see anything like tissue in the lung. You are going to see all artifacts, but here you are looking like a, here it looks like a tissue. So that's a hypatinization of the lung. Now, third sign what you see in pneumonia is a STRAID sign. So when your consultations are not extensive, you will see that part of the lung as if the chunks are removed. It will look like a echo poor area. I'll show how it looks on ultrasound. And it will be surrounded by a normal lung. And this border of a normal lung and this echo poor area will be marked by uh, irregular hyperechogenic lesions. What we call it is a STRAID sign or a fractal sign. So let us see. Now this is a flaps on left side. This is a spleen. You can see a diaphragm here. There is a minimal effusion. I am going to tell you how effusion appears. And this is a lung actually. Now you see this area of lung. It is echo poor. It is less echogenic. So that's your consolidation, and it is actually looking like a tissue. See the spleen, how it looks like, and how this area looks like. So normal lung, there won't be any tissue-like consistency. And you have a normal lung surrounding this area of consolidation, and you see the border, it looks like a bright, hyperechogenic, irregular structure. So that's called a STRAID sign or a fractal sign. Now you can see this video. I hope this video is playing. Please tell me if, I mean, somebody can unmute and tell whether slides are going forward nicely. You can see videos or not. So now you concentrate on this ultrasound. Again, you see the superficial structures. There is a effusion here. I'm going to tell you how effusion appears later on. Now you can see a echo-poor area here. So that's your consolidation. And you can see a lot of shred or fractal sign around. So this is how your STRAID sign or fractal sign looks like in a pneumonia. Now next finding is air and fluid bronchograms. So air bronchograms on ultrasound, they'll appear white. Air appears white. We saw A lines appears white. Whereas fluid bronchograms, they'll appear black. We saw like B lines, it's a fluid. Fluid bronchograms, they'll appear as a black. So if your bronchograms, if they are transverse to the beam of ultrasound, if they are transverse to the beam, suppose your beam is like this, and if your bronchograms are like this, they are going to appear like a punctiform. And if they are in the line of the ultrasound probe or image, then yeah, they are going to appear linear. So fluid bronchograms, they are highly specific for pneumonia. If you see fluid bronchograms, it is pneumonia. Okay. Uh, Now, how to differentiate dynamic and static air bronchograms? So, actually, dynamic air bronchograms, you are going to see the movement of air with respiration. So, with inspiration, you will see the movement away from the lung or centrifugal, and with expiration, you will see the centripetal movement. So, dynamic air bronchograms, again, they are very specific for consolidation, whereas static air bronchograms, where you won't see the movement in the along with the lung is seen in atelectasis. So just to show you images, see these are the punctiform air bronchograms and these are the linear air bronchograms, how they appear. So now look at this video. Again, this is a flaps on right side. So you can see lever, you can see lever. You can see a lower part of lung. It is appearing like a tissue. So this is consolidation, and you can see lot of shred sign or fractal sign. Yeah, there's a minimal effusion also here. And now you concentrate on this area. Concentrate on this area. Now you see with inspiration, the lung will move down towards the diaphragm. With inspiration, you can see there's a movement away, and with expiration, there's a movement towards. You can see the white dots. So these are your air bronchograms, which are moving nicely within the lung, and that is what we call it as a dynamic air bronchogram. You can see nicely, you can appreciate them nicely. Yeah. Okay. So in consolidation or pneumonia, you are going to get a dynamic air bronchograms. You can see the margin of the consolidation is not well defined. You can see there's a minimal effusion. Okay. And you can see like tissue-like consistency. So that's a pneumonia. Now again, look at this video. Look at this video. So again, you have a effusion here. This is a effusion. Yeah, this is all effusion. You can see borders are not clear. You can see a tissue like or hypatination, looks like a liver totally. Yeah, you can see lot of air bronchograms. See, lot of air bronchograms with inspiration they are appearing. Yeah, and you can see this black shadows. They are fluid bronchograms. So again, this is consolidation or pneumonia. Now look at this video. Look at this video. Again, it is flaps on right side. You can see a diaphragm nicely. You can see lever. You can see there is a massive effusion, lot of effusion will show you. And you can see like with inspiration, the lung is moving down. Okay. And then you can see the bronchogram in the lung tissue, which is actually constant. It is constant. It is a static air bronchogram. It is a static air bronchogram. You can see there is no movement within. It is fixed. So this is a static air bronchogram, and you have a clear-cut margins of the lung tissue. So this is atelectasis. So this is how you differentiate atelectasis or a collapse from a consolidation. You can see the floating tip of the lung within the collapsed lung within the fluid, and you can see the static air bronchograms. Yeah. So clear. Yeah. With ultrasound, you can differentiate. If you see alveolar syndrome, you can make out whether it is atelectasis or whether it is pneumonia. So consolidation, you are going to get a dynamic air bronchogram, whereas atelectasis, you are going to get a static air bronchogram. If you see fluid bronchogram, close the eyes, it is consolidation. In consolidation, there won't be any crowding and borders will be ill-defined, whereas in atelectasis, there will be crowding and you will see the clear borders of the floating lung. And usually consolidations will be associated with a minimum effusion, whereas in atelectasis, you will see large effusions. So this is how you distinguish between consolidation and atelectasis. Another thing, what you see in pneumonia or when you see consolidation in the lung ultrasound, you put a Doppler over there, and you will see you can see the increased vascularity of the tissue. You can see there is increased vascularity of this tissue. And as I said, you will see a lung pulse. We already discussed what is lung pulse. Like whenever there is an absent or diminished lung sliding, you will see the movement of the pleura along with each cardiac beat. Each cardiac beat. As the cardiac beat is transmitted through that area, you will see the lung pulse. So again, in pneumonia or consolidations, you will see lung pulse. So I'll just show you the video how a lung pulse appears. Please unmute.
sir, done. You can start.
Can you see the videos?
No, sir, it was minimized, I think. It was stopped.
Okay, just a minute. I need to stop sharing, no? Stop sharing. Where
No,
is the stop?
now it's
I want to stop the sharing and I want to show another this thing. Stop sharing. Now
it
I'm
stopped.
opening the screen. Yeah, now I'm opening. Yeah.
Yeah. Now you
Just-
can share your another
Yeah.
slides.
Yeah. This video is seen.
Yes.
Yeah. So this is see Doppler in the consolidated area. You will see the increased vascularity. I am playing it again. You can see the increased vascularity. Yeah. And now I'm going to show you how pulse. Sorry. So this is how the lung pulse appears. So just concentrate. I'll play it again. So just look here now. I have paused it. I'll play it again. So there is some effusion here. I'll tell you how effusion appears. You can see air bronchograms. It's a shred sign, consolidated lung, tissue-like consistency here. And you now look the parietal and visceral pleura. So this is the parietal pleura now. This is a visceral pleura, and you see how they are moving with each cardiac beat. That is what we call it as a lung pulse. Yeah. Sorry. Yeah. So about consolidation, we saw you will see anterior consolidations, you will see hip patternation or tissue-like sign, you will see shred sign, you will see air dynamic air bronchograms or fluid bronchograms, you will see increased vascularity, and you can see lung pulse. If you are not able to appreciate lung pulse on B mode, you can put a M mode and you can see for T lines what I showed you earlier. So this is what findings we'll see on lung ultrasound in consolidation. Now next is pleural effusion. So again, pleural effusion you can find out very easily on lung ultrasound. There are only three things what you need to look for. One is an anechoic space. Second, the typical anatomical boundaries like chest wall, diaphragm, and the lung. And with respiration, there will be dynamic changes in the effusion. So these three things forms the signs of lung ultrasound of a pleural effusion. So how it looks like. So effusion, I mean, it can be anechoic if it is transudate, exudate, or hemothorax. Echoic effusions mostly are exudates, and if you see septations, I'm going to show you how septations look like. If you see septations within effusion, then it is inflammation or a exudate. So these are the two signs which we see for effusion. Very easy. You put a probe, you have a superficial structures here, you have a ribs on both sides with their acoustic shadows, and then this area we are going to look for effusion. So first sign is a quad sign. What does it mean? Like effusion looks like a trapezium like space where
Video not visible.
it's not video.
Screen slide share is not visible.
Not there.
No, sir.
Just a
Share your
minute.
slides.
But it is showing that I'm sharing.
Again you stop, again you start. Right. Yeah.
Just give me a minute. Stop sharing. Now?
Yeah, came, sir. Came.
Yes, sir.
Okay. So I'll start from this thing, pleural effusion. I'll go back. Not moving. Just give me a minute. Yeah. Okay. Now it's moving.
No, sir.
You can see the first slide now. Pleural effusion.
That we can see. Next slide,
Yeah.
just change.
Yeah.
It's stuck on the same slide, sir.
When?
Now change. Now change.
Now see whether we are moving ahead.
Yes.
Yeah. Okay. So consolidation, I told you what signs to look for. Now effusion, what we actually look for, I'll tell you the signs. So pleural effusion, it is very easy to pick on lung ultrasound. You see two signs. One is a quad sign, another is a sinusoid sign. So basically, you see the superficial structures, you see the ribs on both sides, acoustic shadows, and then this space is an anechoic space. You can see there is no echo here. So first and foremost thing to diagnose effusion is you need to see the anechoic space. So anywhere in the body, effusion will appear as an anechoic. So you have to have a anechoic space, and then it should have a clear-cut boundaries. Now you see the lateral boundaries are formed by acoustic shadow of the ribs. The upper boundary is formed by a pleural line. Pleural line. So if you remember, I told earlier, pleural line indicates visceral pleura if both parietal and visceral pleura are in contact, and it indicates a parietal pleura when they are separated. Now you can see there's a fluid in between. So upper border is formed by a pleural line or a parietal pleura, and the lower border is formed by a visceral pleura, what we call it as a lung line here. Forget about all that names. So this space which looks like trapezium, we call it as a quad sign. So this is how the effusion will appear in anterior areas, what we call it as a quad sign. So you have a borders formed by acoustic shadow of the ribs, you have a upper border formed by a parietal pleura and the lower border formed by a visceral pleura. So this is a quad sign, the first thing. And second thing, if you put M mode across the effusion, you are going to see the movement of a normal lung with respiration towards and away from the parietal pleura. So see, this is a normal lung down, this is a effusion in M mode, this is your superficial structures which appear like a C, and this is a parietal pleura or a pleural line. So your lung is going to move towards the parietal pleura during inspiration, and it is going to move away from parietal pleura during expiration. So this is called as a sinusoid sign. So it indicates there is a free pleural effusion. So on B mode, you're going to see quad sign in the pleural effusion. On M mode, you're going to see sinusoid sign. Now, again, look at this video. We saw this video earlier. So Plapp's point, you'll see effusions nicely. So why Plapp's point examination is very important? I told you Plapp's point stands for posterolateral alveolo-pleural syndromes. So most of the alveolar syndromes and pleural syndromes, unless they are extensive, you're going to get them in the lower part of the lungs. So by default, fluid is going to accumulate in the lower part of the lung, and if it is more, then only it is going to come anteriorly. So any effusions and all, that is a dependent part of the lung. You are going to see them nicely in a Plapp's point. If it is extensive, then you will see it everywhere. Similarly, about the consolidation, unless it is a large consolidation and reaching the anterior chest, you are not going to see anterior consolidations. If it is small consolidations, you are going to see them in the posterolateral part. So that's why Plapp's point examination is very important. So now see here, you see the diaphragm, you see the liver, you see anechoic fluid, that is effusion, yeah, and you see the floating lung inside. So now see this lung, how it looks like. So this floating collapsed lung, it is called as a jellyfish sign. So if you have a massive effusion associated with collapse, you will see a floating tip of the lung within the effusion. So this is called as a jellyfish sign. Second thing, now you see what happens with inspiration. The bad lung or the effusion filled lung is going to cover the diaphragm. So you can't see the diaphragm here. So once with inspiration, you are not able to appreciate the diaphragm. So this is what we call it as a curtain sign. This is what we call it as a curtain sign. And third thing, I told you at a normal collapse point, you can't see the spine beyond the insertion of diaphragm because normal lung contains air. Now, if there is a fluid or a pneumonia or consolidation in the lung, it is going to allow ultrasound waves to go through and you will see the real image, and you can see spine extending beyond diaphragmatic insertion. You can see spine nicely beyond diaphragmatic insertion, and that is what we call it as a spine sign. This is what I was talking about. So see, like if there is a effusion, you are going to see a floating lung tip, that is your jellyfish sign, and you can see spine beyond the insertion of diaphragm. That is what we call it as a spine sign. You can see here. So look at this video, you see the diaphragm, you see the liver, yeah, you see the minimum effusion over here, and you see the consolidated lung down. You can see air bronchogram, dynamic air bronchogram, you can see SRED sign, you can see tissue-like consistency. So this is basically a parapneumonic effusion, and you see down, you see the spine. So it is extending beyond, you can see it beyond diaphragmatic insertion nicely. So that's called as a spine sign. So these are certain signs what you look for. So effusion very easy, anechoic space, yeah, and you can see the sinusoid movements on M mode. Again, now this is one of the video of one of our patients. It's not a pediatric patient, it's a 2-year patient who had empyema of left lower lobe. You can see the video. You concentrate on the first image. So this side is a, you can see, the floating septations within the effusion in the first. And you can see the underlying consolidated lung, you can see tissue-like appearance, you can see the SRED sign. And here also you can see the, it is not totally anechoic, effusion is not totally anechoic, you can see some debris within. So that's your spleen, that's your diaphragm, and this is your effusion again, and this is your or lung line or visceral pleura and an underlying lung. Whenever you see septations within, it means it is exudate. It means it is exudate. So pleural effusion, we saw how to look for. Again, measurement also, it is very easy. There are certain formulas you can read. One formula is 20 into the maximum depth between parietal and visceral pleura. That much ml is the effusion. But by and large, if the depth is 3 to 4 centimeters, it is around say around 500 ml of fluid. So how to calculate, you can read. So next is respiratory distress syndrome. So respiratory distress syndrome, you are going to see two predominant patterns which I have highlighted in red. You are going to see bilateral white lung pattern with no spared areas, that is compact B lines. So you will see a compact B lines without any spared areas as we saw in the severe TTNB. And along with that, you will see pleural abnormalities. So pleura here will be thick and irregular. So how you are going to differentiate TTNB from RDS? Both conditions at a time you may just see the, but then here in RDS you are going to have a thick and irregular pleura, whereas in transient tachypnea you are going to have a thin pleura. Along with that, you can see some small subpleural consolidations or collapsed areas. So these two findings on lung ultrasound are very specific or sensitive for RDS. You will have a bilateral white lung appearance with no spare areas, compact B lines, and you will see thick and irregular pleura with subpleural consolidation. So these are classic signs of RDS. Apart from that, as I said, again RDS is alveolar syndrome. So you can see a lot of other patterns. You can see consolidations with air bronchogram. You will see interstitial syndrome. You will see decreased or absent sliding. As I told, like any inflammation is going to make pleurae stuck together, and in that condition there can be absent or diminished lung sliding. So in RDS also you may say like absent or diminished lung sliding, lung pulse as in pneumonia, and you can see associated effusions. So these two things are very important, like bilateral white lung appearance, irregular thick pleura, and small subpleural consolidations. Now you see here the pleural line is thick. You can see the compact B lines. There are some subpleural consolidations. This is how your severe RDS lung is going to look like. Again, you can see here compact B lines, and you can see thick pleura. You can see some subpleural consolidations. Again, the thickened pleura, irregular pleura, lot of B lines and lot of subpleural consolidations, plenty of subpleural consolidations. Now look at this video. You see like your pleural line is not regular, it appears thick. So the size of pleural line usually is less than 0.5. If it is more than 0.5, we call it as a thick pleura. So here you can see pleura is thick. You can see B lines. You can see some subpleural consolidations as well. Yeah, you can see one subpleural consolidation coming here. Yeah, this area. Yeah, so this is how RDS lung looks like. So as I said, like alveolar syndrome, there is going to be a lot of overlap, but you need to correlate the ultrasound findings with the clinical presentation of the baby, and you need to look for certain particular ultrasound features of that condition. So again, in RDS, you will see all things what you see in pneumonia, but you should know like your clinical presentation of the baby, preterm baby, and your inflammatory markers and all, and you should know like you will have white lung pattern, thick irregular pleura, and predominantly you will have a subpleural consolidations. Now let us see whether ultrasound will help us to give a surfactant or not. So this was one of the prospective cohort study by Martin et al. And group, where they studied less than 30 weeks gestation age newborns who were on CPAP, and they were given surfactant based on the FiO2 criteria, what we regularly follow. And they did a lung ultrasound score. So lung ultrasound score for RDS, how we do, it's very easy. You do lung ultrasound at 3 points: upper anterior, lower anterior, and lateral. So 3 points on each side. So points total. Yeah, and from 0 to 3 based on the findings. So minimum score will be 0 and maximum score will be 18. So upper anterior, lower anterior, and lateral. Now how you are going to score it? So if you see A pattern, so that is like A lines. If you see A profile, score is 0. If you see B pattern, that is more than 3 B lines between 2 ribs, you are going to call it as a B pattern, and that is given a score of a 1. If you see means you will see compact or crowded B lines with or without subpleural consolidations. With or without subpleural consolidation, that you will give a score of 2. And if you see extensive consolidation, that you will give a score of 3. So see, if you say like for example upper anterior, you see only B lines, so score is 1. Lower anterior, you see some subpleural consolidations, that is 2. And you lateral area, you see extended consolidation. So your total lung ultrasound score becomes 6. Like that you are going to calculate. And what they found is a score of 6 to 8. A score of 6 to 8 predicted the requirement of first dose of surfactant, and score of more than 10, they did it after 10 hours, and it predicted requirement of second dose of surfactant. Look at one more study. This is a landmark paper which published 2 months back, ultrasound trial. Here what they did, newborns less than 32 weeks with respiratory distress requiring CPAP, they divide into two groups, ultrasound and control, and they performed lung ultrasound at 1 hour of life, 1 hour of life. And if your lung ultrasound score is more than 8, as I told you how to look for lung ultrasound score, if it is more than 8, they give surfactant independent of FiO2. And if your lung ultrasound score is less than 8, then they give surfactant based on the FiO2 criteria. Whereas in the control group, they give surfactant just based on the FiO2 criteria. So what, now just to show you how the lung ultrasound pattern looks like. If your lung ultrasound score is more than 8, you're going to look, see the lung like this. When it is less than 8, you're going to see lung like this. So lung ultrasound allowed for early surfactant therapy. Like you could give surfactant by 1 hour versus the duration was up to 6 hours just based on the FiO2 criteria. So lung ultrasound improved timeliness of giving surfactant as compared to FiO2 criteria alone. There was a less FiO2 requirement and better oxygenation in lung ultrasound group. After giving surfactant, these patients, they required less oxygen and their oxygenation was better. So there was a reduced oxygen exposure in lung ultrasound group, which further reduced the oxygen toxicity. That's why the lung ultrasound score you can utilize, particularly in the babies less than 34 weeks within 1 hour of life, to decide to give surfactant. So it will help you to guide surfactant therapy and retreatment as well. Now coming to bronchopulmonary dysplasia, again it is a alveolar syndrome. You are going to see a lot of overlap. So you will see non-homogeneous. So bronchopulmonary dysplasia and RDS, they are different. RDS is homogeneous. You will get it all over. Whereas bronchopulmonary dysplasia, it will be non-homogeneous. So you will see non-homogeneous B lines. You will see multiple subpleural consolidations, and you will see thick pleura. So again, as I said, you have to correlate with the clinical findings. So obviously, if you see these findings in a baby who is just born and less than 30 weeks, it is RDS. And if you see in a 28 weeks preterm after 1 month, this finding, this is DPD. So you have to correlate clinically. So bronchopulmonary dysplasia will have a non-homogeneous B lines, multiple consolidations, and thick pleural line. So you can see here a lot of subpleural consolidations, pleural line abnormalities, non-homogeneous B lines. So there's a lot of overlap. So again, same thing, subpleural consolidations. Yeah. Okay. Now again, meconium aspiration syndrome, again same. It will have most of the features of pneumonia or consolidation. Again, you need to correlate with the clinical picture and history. So you will see lung consolidations with air bronchograms, you will see pleural line abnormalities, you can see B profile or pleural effusion. So these are different lung ultrasounds in meconium aspiration. You can see a lot of consolidations, B line profile, again subpleural consolidations, thick pleural lines. So basically, all alveolar syndromes, there will be overlap of findings. You need to correlate them with a clinical picture. Now, you can differentiate between cardiogenic and non-cardiogenic edema based on the lung ultrasound. So, what you see, so when you have a cardiogenic edema, normal lung sliding you will see, whereas in non-cardiogenic lung sliding will be absent. It is just the summary of the findings what we saw. So in cardiogenic, you will have a normal pleural line. In ARDS, you will have an abnormal pleural line. Here, the distribution of B lines will be homogeneous. Everywhere it will be there, whereas here it won't be homogeneous. More in the parts. There won't be any consolidations in a cardiogenic pulmonary edema. There won't be any lung pulse in the cardiogenic pulmonary edema, and effusions are common with cardiogenic pulmonary edema, and they are less common with ARDS. So now And there are two protocols which are defined in adults based on the ultrasound, and we can adapt them in a newborn. One is a blue protocol for respiratory failure, and second is a false protocol for circulatory failure. Now, see the adapted blue protocol for respiratory failure. This slide is very important. This slide summarizes entire lung ultrasound. So these are the profiles, basically what you see in lung ultrasound of the newborn. It can be either A profile, B profile, or C profile. So A profile, we know normal lung, you have a A lines, lung sliding and thin pleura. That is your A profile. A dash profile is absent lung sliding with A lines, and that is pneumothorax. B profile means you are going to see lung sliding and there will be a lot of B lines. So you are going to see in transient tachypnea of newborn or a pulmonary edema of a cardiogenic cause. B dash profile is basically absent or decreased lung sliding along with B line. So you are going to see it in RDS or meconium aspiration. And C profile is consolidation. So consolidation you are going to see in lot of newborn conditions: pneumonia, RDS, meconium aspiration, BPD. So B dash profile and C profile are basically consolidations or pneumonias. B profile is TTNB. A profile is a normal lung, and A dash profile is a pneumothorax. So just remember this 1, 2, 3, 4, 5 profiles: A dash, B dash, and C. There is something called the false protocol, which is for a circulatory failure. And here, what we basically do, I'll just go through next slide. So, whenever you get a patient with acute circulatory failure, you do a simple lung ultrasound and 2D echo to rule out two things. One is tamponade and one is pneumothorax. So on simple echo you see there is no tamponade, and on lung ultrasound you see there is no pneumothorax. Then you have ruled out the obstructive cause of a shock. Then you see what is your lung pattern, whether it's a profile or B profile. If you see B profile, then this is a cardiogenic shock or cardiogenic, then you treat it accordingly. Suppose you see A profile. Suppose you see A profile. You have ruled out tamponade and pneumothorax. There is no B profile. So your obstructive shock and cardiogenic shock is out. Suppose you see A profile. Now you are left with only two possibilities. Either it is a hypovolemic shock or it is a septic shock. Now here you give up fluids and see the response. You do the serial ultrasound. If there is a clinical improvement, it is a hypovolemic shock. And if there is no clinical improvement and you see like B lines are appearing from A profile, your pattern is changing to B pattern. Then what it indicates that there is a interstitial edema or pulmonary edema. So appearance of B lines on ultrasound is the first clinically silent step of a edema. So you can pick up edema well ahead of time before it manifests clinically by lung ultrasound. So at the point where your A profile starts changing into B profile, it means your fluid have started accumulated. So if you see that there is no improvement and B profile is appearing, then it is a septic shock and you treat it accordingly. So even this false protocol to guide the fluid management, we can adapt in pediatric or neonatal age group. Now let us see whether lung ultrasound will help us to assess the lung recruitment. So even bedside assessment of a patient with lung ultrasound will help you to see whether lung is recruited or not, and it will avoid lot of x-rays what we do usually. So see, this is a case of a pneumonia. You can see the consolidations and air bronchograms. It is without PEEP, and once the PEEP was given and the ultrasound you have repeated, you can see the recruited lung. So you can make out whether recruitment has happened or not. So bedside ultrasound will help you to know whether recruitment has happened or not, and you can avoid taking X-ray to look for improvement. So you can see here there's a lot of consolidation, and after giving PEEP here you can see the you have got a profile. So this is a well aerated lung, means whatever the collapsed or consolidated part was there, that is aerated. Again, here you can see there's a lot of B lines, so basically B profile or edema. And once you give a PEEP, you can see like this B lines which were compact, you can see them separately along with a normally aerated tissue. So lung ultrasound, you can use serial lung ultrasounds, you can use for bedside assessment of the recruitment. Now, there is one upcoming or a new thing which we call it as a recruitment manuals for ARDS. Personally, I don't have an experience with the recruitment manual for ARDS. I have not done it. So basically, what they do it here, it's a strategy to transiently increase the transpulmonary pressure to open the collapsed alveoli. So in turn, it is going to improve the gas exchange and the blood oxygenation. So the main benefit of recruitment maneuver is that it is going to cause resolution of atelectasis in regions in the dependent part of the lung. And for that, with ultrasound, you need to identify the areas of a worst lung aeration pattern. So whenever you have a ARDS, you need to do the systemic ultrasound of all areas, and you need to find out the areas of the lungs where the lung aeration pattern is worst. What I mean by either it is a B dash profile or a C profile. Now, there is a suggested algorithm to assess recruitment maneuver by ultrasound. There are 4 steps. We'll go one by one. So the first step, you need to see whether you require a recruitment maneuver. So where you're going to require a recruitment maneuver, if your lung is collapsed, then only you're going to require a recruitment maneuver. So with ultrasound, you're going to see the areas of the lungs, whether they are normally aerated or there is a collapse. So if there is a normal aeration, you are not going to require any recruitment maneuver. You continue the same protective ventilation what you are doing. If you see the area of collapse, like here you can see in this image, you have a subpleural area of a collapse, alveolar prolapse and lot of B lines. So that is a patient who is going to require a recruitment maneuver. So in ARDS, if you see the collapsed lung on ultrasound, then that patient is going to require a recruitment maneuver. Now next step is you need to see the hemodynamics of the patient, whether patient is stable or not. So if patient is not stable, he is not the candidate for recruitment maneuver. You need to stabilize the hemodynamics. We need to give IV fluids, inotropes, or vasoactive agents as per patient's condition. If patient is hemodynamically stable, I mean he is not in the shock, he is not requiring any vasoactive drugs, then you can go ahead with the recruitment maneuver. So first 2 steps are to assess the requirement, like 1 to see whether there is a collapse, and second to see whether patient is stable. Third step is to find out the third and fourth I am describing together. Third and fourth step is to find the opening and closing pressure. So basically once you find that the patient requires a recruitment maneuver, you have identified the worst aerated part. So you are going to do a serial ultrasounds in that part and you are going to monitor. So what you do basically, you increase the PEEP between 2 to 5 centimeters based on the patient's age, and keep ventilation for 2 minutes with that PEEP, and you do ultrasounds after 2 minutes in sequence. So see here, now this is a patient where you have a B pattern and the alveolar collapsed lung. You have increased PEEP by 2, you have kept it for 2 and observing your with ultrasound. You are doing it till the time you see that A pattern has come. From C it has almost come to the A pattern. I mean the collapsed alveoli have recruited or opened. You can see here there is thin pleural line and there is no subpleural collapse, and there are hardly any B lines. So this is
ಬರೋದಂತಂದ್ರೆ ಬರೋದು.
so this
ನನಗೆ
is
ಏನ್ ಗೊತ್ತಾ, ಇವಾಗ ತಾನೇ 3 weeks ಆಯ್ತಲ್ವಾ, 4 weeks ಆಯ್ತು. ಸೊ ಇನ್ನ 2 weeks ಐ ಶುಡ್ ಬಿ ಯಾಕೆ ನನ್ನಿಂದ ನಿಮ್ ಕಾಯಿಲೆ.
yes, okay, fine. So this is your opening pressure, or this is your lung is recruited. So once your lung is recruited, you need to do a titration downwards to get a PEEP where you are going to get a good oxygenation. So from here you are going to decrease your PEEP by 2 centimeters, keep it for 2 minutes and get ultrasound done in that area. And you come down like this, and now you see here, again you can see the collapse is appearing. So this is your closing pressure of the lung. So from here you go 1 or 2 steps up. So 2 centimeters or 5 centimeters you increase the PEEP and you leave it there. That is your optimum PEEP to get good oxygenation without any collapse. So this is what we call it as a recruitment manual. Now, just to see, show you some images. These are from one 3-month-old infant where they tried the recruitment manual. You can see the C pattern, the consolidations. Initially, PEEP they set 20, then they increased by 5, and they did serial ultrasounds. You can see the changes. So this was at 25, this was at 30, this is at 35. This is right and left, right and left. You can see the improvement in the aeration. So you can see sparse B lines and some intermittent, what you say, normal aerated areas. And they reached up to the PEEP of 35, and from there they started titrating the PEEP downwards, and they came to the PEEP of 18, where they got a good oxygenation without a collapse. And then next 3 days they could extubate that baby. So this is what the recruitment manual is. They'll increase the PEEP slowly to a particular level, and from there you need to decrease the PEEP till the point where you get a good oxygenation without a collapse. Now, what happens with lung ultrasound? We can't assess the PEEP-induced lung hyperinflation. So, lung ultrasound, it should not be used as the sole method for PEEP titration. You can't just say ARDS, the lung is there, and you can't just do ultrasound and keep on increasing the PEEP or keep on decreasing the PEEP. You need to see overall picture. You need to see your blood gas criteria. You need to see your oxygenation indices. You need to see your graphics, and based on that, you need to decide about recruitment. So this is how ultrasound can be used for a lung recruitment as well. So we saw almost like the abnormal ultrasound patterns in all the conditions. We saw how lung ultrasound can help us to give surfactant, and briefly about lung recruitment. Now, there are certain limitations of lung ultrasound as well. As I said, unless a structure comes to the surface, you can't see it with lung ultrasound. So, any deeply located structure, you cannot directly visualize. That's why we see like collapse point examination is important. If there is a deep-seated pneumonia, if you do ultrasound on the anterior part, you will see a totally normal lung and you will label it as a normal ultrasound. So that's why you do it at all areas. Second, even if you see B profile or interstitial syndrome, you cannot easily differentiate between cardiac and non-cardiac cause. Again, just last slide we saw, like to see whether lung is recruitable or not with ultrasound, we need to have a non-irritated area adjacent to visceral pleura. I mean, you need to have some subpleural collapse. Then only you can make out, or you can find out whether this lung is recruitable or not with ultrasound. And if a patient has a subcutaneous emphysema or alveolar overdistension due to mechanical ventilation, you can't use lung ultrasound because there will be increased air into the lung, and with ultrasound it will appear as a normal lung rather than a pathology. So these are certain limitations of lung ultrasound. So my take-home messages for both the classes together: point of care lung ultrasound is a study of artifacts. Neonates, high frequency linear probe, longitudinal plane and 12 points. A line stands for air, but it doesn't distinguish between pleural and alveolar air. P lines is for water. A profile, we already know what is A profile. A profile is normal lung. A dash profile, pneumothorax. B profile, edema. And as I told you, B dash profile and C profile, it can be pneumonia, RDS, meconium aspiration, or BPD. Effusion, you will see anechoic space. Lung ultrasound has very high diagnostic accuracy, and it can be very useful tool in our hands. So with this, these are certain glimpses of our previous workshops which we did over last 3-4 years. It is a big miss for all of us. and I hope this pandemic will get over soon, and maybe next year we'll have a face-to-face workshops. With that, keep calm and keep scanning. Thank you. Yes.
Thank you, sir.
Prashant. Prashant. Prashant.
1 second, sir. It comes on. Yeah.
Sarji.
Can you show the live demo, or you want me to show?
Sir, you show first. I have.
Yeah,
It's a COVID
because
unit.
already. Okay, before showing the live demo, I want to, because I don't have any pneumonia cases at present. At present, I don't have any pneumonia cases. I am sorry. Or I don't have any other, the lung recruitment cases also. I am sorry. So just I will ask you one thing. Any doubts you people are having regarding the lung ultrasound? Any doubts? I'll take another now 3 o'clock 33 minutes. So 3 o'clock up to 40 minutes, 7 minutes is for the question and answer. 20 minutes live demo we are going to show you. Please, any doubts? Anybody is having any doubts, please, sir. Anybody? Kamal sir? Vaideshwaran?
So,
Vaideshwaran?
I think we'll have to do it. Right now, there are few things like all those signs. They're not very clear. So like you have to look for also jellyfish, then curtain sign, spine sign, two things. But they'll all be there only when you have a typical case, I suppose.
Sir, if there are cases, because see, your institution is very big, sir, very old, very famous,
Yes.
and it is a monument, and it is a a wisdom of place. So you will get more cases. So like if I would have been in your this thing,
Yeah,
I would have
yeah.
showed all the things today, because you will get a lot of concept. You will get a lot of
Yes,
things.
course.
Sir, here actually we are having today, we are having less cases. We are having very less cases.
Yes,
but however, I'll try to show the normal lung, how it looks. What do you mean by pleura? Sir, everybody should remember one word. So number one is, first think there are three sections. See my hand, sir. 3 sections. Number one is skin, subcutaneous tissue, fat. This is one layer. Second layer, skin, subcutaneous tissue, fat. Second layer is pleura. Third layer is lung. Remember, in ultrasound lung, we have only 3 things to see. 3 things to see. Okay. In that 3 things, we spoke for 2 days. So very easy to remember. Okay. In the center thing, this fellow is there, no center fellow is a pleura fellow. Only because of that, everything is depends on that. If he is moving very happily, Center, pleura, that means everything is happy. If pleura fellow is not moving, then there is pathology. If pleura fellow is very thin, everybody wants to be a lean, handsome, without tummy. Everybody wants it. So if the pleura is very lean and very beautiful, so that means healthy pleura. If the pleura is humpy, lumpy, bumpy, that means the pleura is not healthy. So below there is a problem. So that's all. Number one word. Number second thing, just above one, usually above one in neonates, usually normal. Usually, unless otherwise, there is a subcutaneous emphysema. But in the adults, bullet shot injury, what is that, knife injury, or some trauma, skull chest injury, all those things in adults, we do see that there, this layer is important, skin subcutaneous tissue. Then come to the lungs. Lungs, remember, you should not see anything other than the A lines. If you are seeing something other than the A lines, that means there is some pathology. That's all the lungs. Simple word. Okay, now we will try to show you what is this. Pawan. Pawan. Call Pawan. Right. ಹಿಂಗೆ ಇಟ್ಕೋಬೇಕು ಮಗುನ ಅಲ್ಲಾಡಿಸ್ಬಾರ್ದು ಅಂದ್ರೆ ಇದನ್ನ ಇಟ್ಕೊ ನಾನು ಹೆಂಗೆ ಹೇಳ್ತೀನಿ ಹಂಗೆ So now we are going to take very quick. I'll take and I'll finish it off because I thought he will take 30 minutes. Anyhow, 1.5 hour our person where he is there. Anyhow, no problem. We will take very fast here. First of all, do the hand washing. We have done the hand washing. However, whatever, I touched my mobile. So that is the reason I'm still doing the, what is it, saline hand washing. Sorry, what is it? Sterilium hand washing. Once I do the sterilium, always in a neonate, try to use linear probe. The linear probe. So we have washed it.
नहीं मैं अभी खा रही हूँ।
And choose this one. In the pediatric, either musculoskeletal you can go, but one thing, which one to choose, sir? For abdomen. For abdomen. Number one. For lungs, because all these two portions, there is moving organs are there. In abdomen, intestines are there. It is always movement is there. In chest, so you know that if lung is coming down, upper chest is goes up. So because it is constant friction and movement is there. If it is there, there is a tissue harmonious. So THC, tissue harmonious compensation or reduction. That means each cell is moving, means it will give some signal. Okay, that will reflect. For that, I am trying to use pediatric and abdomen. I will try to use. Okay, to reduce the THC. Otherwise, if you use something in your report, tissue harmonic image, come near to me here. Tissue harmonic image. Okay, in your machines it will be there. In all the machines, see dear friends, this machine is almost 25 years back machine. Everything is there in all the machines. Only we should know. We should not blame on machine. Okay, that is old, that is not there, this is not there. Everything will be there. Only our brain won't be knowing. So dear friends, very clear, our brain won't be knowing. So request your provider of the ultrasound machine, take a lesson from him about the machine. Okay, number one. Number two, call the specialist and tell him to show how to use the knobs. That is called knobology. Then only you try to play with the machine. If without the two things, we want to catch the machine and see immediately MRH, immediately IVH, so immediately PDA. But we won't be knowing knobology. Then we'll start blaming machine is not good, it is old, it is not working. So the two things. And like how my brother was there, he never allowed me to touch his bike. He gave me for 1 year. First you wash the bike, know about the parts, then you start knowing and ride the bike. That's what he was telling me. So now also I am telling, before you touch the machine, know the knobology, then it will be easy. So now I put on the abdomen. Okay, I am using linear probe. If the linear probe is not there, doesn't matter. Okay, come here. If linear probe is not there with you, it doesn't matter. I have the linear probe. Then come here. Come here. Then this one, this one. No, in melke. Specs ಆಗ್ತಿದೆಯಾ ನಿಂಗೆ ಗೊತ್ತಾಗ್ತಿಲ್ಲ ಎಲ್ಲಿ ನೋಡೋದು. Yeah, okay, hold it. See, depth is very important in the lung ultrasound. See, now I am reducing the depth. How much hardly in a neonatal chest you want to see? 2 centimeter below the skin or 3 centimeter below the skin. See that how many centimeters you are going. How many centimeters you are going. So now I will press this or I will press this. So it will change. Okay, come here. Then no, ಅದನ್ನೇ ಕಷ್ಟಪಟ್ಟು ಹಿಡ್ಕೊತೀಯ ಇಲ್ಲಿ ಯಾಕೆ ಅಷ್ಟು ದೂರ ಪವನ್ ಬಾಯ್ಲಿ ಅವನು ಗೊತ್ತಿಲ್ಲ ಹಿಡ್ಕೊ. You just can you relax ಆಗಿ ನೋಡು ಇದು 1 centimeter. So this is 1 centimeter is there. Okay, see now I am pressing. This is become 2 centimeter. Press this once again 1 centimeter. So play with 2 or 3 centimeter. Depth is very, very important. Then come to the other one. Just see the color first. See, it has become black overall. It has become white. So gain is also important. Very, very important. And suppose if you find there is some pathology here, then see this point. You have to now concentrate here, everybody. There is called focus. Can you see these two things are moving in between here? It is focusing. Can you see it is moving? So number 1 is depth. Number 2 is gain. Number 3 is depth. Depth, gain, and focus. These 3 things are very important in lung ultrasound. So knowing the knobology is important. Now, once you have done this, taking the abdomen, still if you are not able to get the proper image, then slowly come down here. Yeah. Okay. I am going to press this and finger. Come near, come near, come near, come near. Tissue harmonic image is a THI. Press this. See this, what happened? See, I am pressing THI. What is happening? Okay, 2D, then THI. And suppose here there is something is there. Can you see 5, 10? Here the frequency is very high this side. That means here you might get a quality very good. So here you might get a quality low, 5. You can see this 5 and 10. So if you want to adjust, what you have to do, see this. Here it has become more smooth because Hertz is very good. So this side is very bad. So this one, can you come here? Fusion. Can you go there? Okay, can you focus and with this? Just keep on pressing. Okay, see this is now everywhere it is almost in the center, it is coming very good. But this corner, it won't be good. But we are focusing this. This is very important. Fusion, tissue harmonic image is very important. Now I am going to put Danya. Salpa barbek baby. I have to come near baby. Just can you just remove the baby's cloth? Just come. And in my hospital, I know that incubators are very good for less than 1000 gram baby. Since that incubator previously we used to have so much infection. I know some machines incubators are very good. Okay, excellent. But we do use the warmer with the covering of the plastic. So please don't think any other way. Yeah, slowly. Remove. And remove the temperature probe also for 1 minute. Take your own time. So once again, I will tell you. Once again, I'll tell you. One is tissue harmonic image. First, which mode you will see either abdomen or, sir, can I see head? You can even choose the head because there also arteries are pulsating movement, but brain won't move as the chest is moving or intestines are moving. So that is the reason use the abdominal mode. It is more better, or musculoskeletal mode. That is still better. Why musculoskeletal mode is because each tissue will be moving. Each tissue will be vibrating. Suppose nodama adu sound off maadu. No, adala ನೀನು ಏನೇನೋ ಆಫ್ ಮಾಡಬೇಡ. ಫಸ್ಟ್ ಇಯರ್ ಸ್ಟೂಡೆಂಟ್ ಬಾರ ಈ ಕಡೆ. Just stand with me, dear sister. Take care. No, ventilator off ಮಾಡಬೇಕು. No. Okay. So what I was telling is, so use musculoskeletal, there is no problem. Abdominal, there is no problem. Okay, try to use HI, tissue harmonic image. Now, I am going to show you people. See, the probe is very big. You are going to get a little smaller probe than this, 12 to 13. Okay, here, 12 to 3. It's very clear. So it is very clear from 3 hertz to 12 hertz. That means that much fine also it will go, that much even very deep also it will go. Okay, but this one is very big for a preterm baby. But I am using this one because I don't have so much money to buy a smaller probe, means this much length. So I am using this for the even neonatal hip as well as the even central lines as well as the septic arthritis as well as for this purpose. Suppose if you are rich, you can buy like our Dr. Prashant Gowda, you can go ahead and buy a hockey stick of 3 lakh rupees machine, 3 lakh rupees probe. It is having 15 to 18 hertz probe. You will get all the pleura layer also you can see in that. It is very expensive hockey stick probe. Okay, I think so he is having it. He is rich kid. I am not. So I am using this. Number 1. Number 2, but at least in this, you will get a smaller version that also can be used. Number 2. Okay, for a smaller baby. So now what we will do is we'll try to take, and one more thing, dear friends, please see my hand. See my hand. Can you hold this? Okay. See my hand, please. If the lung is like this, because lung will be like this. It is moving like this, it is coming out. Moving like this, coming out. So if it is like this, see here, you can keep the probe like this. It is perpendicular to the lung. But here also don't try to put like this. It is not perpendicular. You have to change something like this. Always probe according to the curvature, the lung, not the chest. How the lung inside, visceral pleura. Okay, visceral pleura or parietal, because parietal pleura is attaching to the subcutaneous tissue and other things, right? Yeah, visceral pleura is attaching to the what? To the lungs. So to the visceral pleura or to the lung, probe should be perpendicular. Sir, I am putting anterior also like this, here also like this. You don't get exact image. This is a practical tip for the. Now we will go. Because another 10 minutes only is there. I know that everybody wants to run for the practice. So, number 1, I am trying to keep on the chest. I know that gel is very cold. Baby might cry. Don't have a gel warmer. Okay, try it. In case if you have it, buy it, because it is only 30,000 rupees or 15,000 rupees. Ask, okay, ask your boss to get it. See that it should work continuously, otherwise somebody will jack it. Okay, dear friends, see, I am going to keep the probe. Please see this, how the lung is moving. I am keeping perpendicular. See here, how I will know I am not keeping perpendicular. Number one, here see, I can see the lung. It is perpendicular, but here it is distorted. Do you think here baby is having pneumonia? No, because this is not perpendicularly I have kept. Because here if you'll see tissue-like sign, shred-like sign, then if you'll remember all those things, so more reading, more confusion. So read less, do practice. It is more better. So here perpendicular is there. And one more thing, I want you people to follow my arrow. I think so. You come near. Yes. Yes. Can you people see the arrow? You can see the arrow. See here the pleura. And see this pleura is little distorted. That means here I have not kept it perpendicularly. Here I kept it perpendicularly. If you persist, then you go to this area and please be like that. See, I'll go to that area and I'll show you how beautiful that pleura is. See here. See this area, pleura, I kept it perpendicular here, but here it's not perpendicular because it is a curvature. So remember always, then don't, oh, here something is there problem. No, don't think. And just see the lung pulsation. That means if each heartbeat, lung is also pulsating. Then that one is shimmering line sign. What do you mean by shimmering line? Suppose if you are going in a car in a summer place, you know, I don't know what English word you will see. We feel like roads very far away, there will be water. What you will call in English? Okay, mirage. Okay, that mirage, you know, that if you come near, that water will be very like we'll feel like water, but it will be very glittery. That glittery word is called shimmering. It's like a water. It's like a, see my hand. It's like water moving and shining on the top. So shimmering line. Okay, that's what here you can see. Don't go with the English words and all, whatever words you know, that is more than enough. See this. See, you can see lung pulse. Even lung is pulsating here. And see, see, now it is moving. See here, this one, what he is telling is, it's a little, okay, B lines, 1, 2, 3. See, you can see lung pulsation. You can see shimmering line, means sliding sign. So do you think is there pneumothorax? If lung is moving like this, pericardial visceral pleura, this pleura, no, there is no pneumothorax. See how many seconds it took? It took not even 1 second or 2 seconds. So X-ray, how many? We have to go down, send first year PG or intern, call her, call this. See, there are so much headaches. Okay, now this is, I am keeping it sagittal view. I am seeing all the things. And now go to that pictures. Please, dear friends, see this. If you'll go, I am coming very near. That means my heart is increasing. Okay, number one. See this. What I am doing, this is 12 hertz this side. This side of the probe is 12 hertz. So nicely I can see my things. This side of my probe is 3 hertz. See, I cannot see. Not only angling, that also you should keep it in the mind. Okay, 3 hertz, 12 hertz. See, it's so beautiful. Okay, now what all the things you can see, dear friends? if you'll see more detail, this is the maximum. I can go 1 centimeter below. If you will see here, see this, if you can come near to me, near to that, near. Okay, hold on. See, I can see 2 lines. One, usually, if you are having more that I told you hockey stick or more 15 to 18 hertz, see here I can see 1 line just above more white line. You can see. That means this is a visceral pleura, this is a parietal pleura. Parietal pleura is more brighter. Visceral pleura is not so brighter. Okay, and now 1. So this is the one, skin, subcutaneous tissue. This is the muscle. This is the muscle. Skin, subcutaneous tissue. This is the muscle. This is always fixed wherever you go in the body. This is also it. This only this fellow is moving. Yes or no? If it is fixed, how it looks like in the M mode. Now I will show you in the M mode. Then you will understand what is seashore sign. Okay, be with me. Now I am putting M mode. In between, this is a rib. Okay, in between I am showing. See, this is fixed. See, this is the one. This is pleura, bright. Bright is pleura. This is lung. See, this is a waves. This is sand. See, shore sign. Water is coming. What? This is the water because it is always stagnant. It's a skin, subcutaneous tissue, muscle. Muscle will be having its own like a myofibrils. You people know myofibrils. So this is myofibril. This is like a water. This is a shore because this is moving because air is whatever ultrasound is there. It cannot penetrate the air because ultrasound is a bad enemy to the air. So this is sand because each movement lung is moving. It is distracting and coming. So it is appearing like a sand. So sea, sand, shore. Water is coming. You understand? You people are staying in Chennai. You will be knowing every day how the beach looks. So seashore sign, normal. Suppose if there is air in this, everything appears like this. Like this, everything appears. You don't see this. You don't see this. Everything will be appearing like above. Like above. This is more better than barcode sign. Theory of लिख लो. You can write in theory. Barcode sign जैसा दिखता है. But when you see practically, brothers, don't follow English people. Follow what you see. Because easy to remember, easy to learn, easy to diagnose. Barcode मतलब ऐसे ही रहना क्या? It need not be. Always, do you think it should be like that? Need not be. See, whatever on the top, it will appear like that only. Because see, it is all barcode like. So you understood what you mean by barcode, what you mean by seashore. Okay, now only you understood. Now, so first fixed is muscle. Second one is pleura. I told you 2 layers. Suppose then I told you if it is beautiful, thin, nice, beautiful like a girl, then it is healthy. Fat, lumpy, bumpy, everywhere lumpy, bumpy, that means unhealthy. 2 things. Come to the lungs now. So 2 layers I told you because I have another now 4 o'clock. I'll take only 5 minutes. Sorry, please, dear friends, don't feel bad. Now I am from 1 centimeter. I am increasing it to the 2 centimeter. I am going to the lungs. But this lung is normal. See, this is A line. This is same thing. Equidistance. Whatever this pleura is there, equidistance A lines. You can see one equidistance from here to here equidistance from here to here, equidistance. That means A lines means air is there in the lung. What is there normally in the lung? Air we should be there. So A lines is air. That means no pneumothorax. Everything is healthy. If water is replaced, instead of A horizontal, AH, remember, instead of A lines, it will be like this B lines. Water means it's all water is there. That water is connected to the, in between each alveoli. There are more than 10 alveoli or 20 alveoli or 5 alveoli. It is connected between the septums, interstitial space. All those interstitial connected to the lobular. That lobule, each lobule is connected once again directly to the pleura. That means each lobular space equal to 0.00000 ml. So whatever even 0.000 ml fluid is extravasated from the alveoli, that will directly goes to the, directly means just imagine there are so many balloons kept, very tightly jammed balloons. One drop of water. That means that water will fill all the areas. It's full jam-packed balloons. No, not even 1 ml space in between. It will directly come surface like that. That fluid will come to the surface of the pleura. If the alveoli pathology is there, that time pleura will have a lumpy, bumpy appearance. You understood why pleura is thick, and pleura will tell indirectly there is some pathology exactly below that. You understood. So suppose more fluid is there, what happens? Below the pleura, subpleural consolidation will start. Not after the pleura. Subpleural, below the pleura, in the lung, there is a consolidation here. You understood? Because more, I told you, surface. No place below to go. So that time that lung is become wet. Subpleural consolidation. So everybody understood the pathophysiology. Then you will understand the ultrasound beautifully. Subpleural. Now you understood here, if there is a black, okay, here, then somewhere here the problem. Search where is it. Then if it is very big, what is the tissue like, or whatever the black things are there. See in this, if the bronchus is having, I think so, they have shown the bronchogram. If the air is moving or not, the pathology is in the alveoli. That means this baby needs antibiotics. Suppose if there is no air bronchogram, after the collapse consolidation, that is called consolidation. That means pathology is in the alveoli. That means pneumonia. If air bronchogram is there, suppose this much part is becoming tissue like black, but air is not moving in the bronchus. That means somewhere some bronchus or bronchiole is blocked because of the mucus, or some pathology, or some malacia. Or if it is a pediatric, some nut, bolt, something has gone into the lung, child has swallowed, it has gone into the lung. So, but can you diagnose in X-ray? X-ray you will diagnose simple collapse consolidation. So suppose if it is collapse or consolidation, X-ray won't tell, because it will same appearing. Only what is it? Trachea is full this side or that side. अरे वो डेवलपमेंट होने के लिए कितना टाइम लगता है भैया? And once again, if the little deviation is there, that side neck, it will be very difficult. I am not telling chest X-ray is outdated, but chest X-ray is a gold standard. But the thing is, this is a newer one. Previously, there was no Android phone. Now everywhere Android phone, Android TV connection, so easy life. Like that, ultrasound will tell you whether it is collapse, whether it is consolidation, whether it needs a bronchoscopy, or whether it needs a proper antibiotic. After giving the antibiotic and nebulization, if it is not improved, then you will think of doing something else. So there is so much useful. So that's what the telling. Some people will start antibiotics for 5 days, not reduce. But here, baby might have swallowed something, it has entered inside. You can diagnose in ultrasound. So now, I told you this one, I told you pleura, I told you this. Pneumothorax, I told you if it is there, everything is A lines. But it is called a barcode sign or whatever the above it is there. You have, and the tissue, and one more thing. Please, dear friends, now you see what you mean by lung pulse in M mode. See here, come near. See, each there is a break. If the picture is not clear, you people have to tell me. Break
between the lines.
Again. See, I can show you break here, break here, break here, break here. This is called a like something. Break lung pulse means it is like putting a tube under the aquarium. Okay, one long tube giving the oxygen or air. That air is coming below like this. Air is coming below. See here. That is called lung break sign or lung pulse sign. If it is there, even pneumothorax, that side is ruled out. Okay, and suppose if in an adult only, because we are now in the neonatal, I don't want to talk towards the adult side. Okay, so it is a simplified in 20 minutes, this much. If you want the lung ultrasound, if there is a cases, each and everything, because one day in the critical adult side, critical, what is it, ultrasound, this thing, when I was telling, I have seen the pleural nodule. Then I told him, please send him for the CT scan. He might be having secondaries. Then they laughed. But next to him, his relative was sitting. Sir, you were telling something to them. So can I take it? Because he came with a history of just simple cough. They were treating like a tuberculosis. Then I told him, just try to take it, but I'm not sure. Because it was a practical. Then he forced to do the CT scan. Then they found out cancer. It was going towards the pleura. Multiple nodules were there in the pleura. It was very evident in the pleura. So, dear friends, don't hesitate to learn the ultrasound. This is a quick, like a 2 minutes noodles. Mummy will do, kids will eat like this. This is a quick review, dear friends. So, over to Prashant and Kamal Nath, sir. Sister, clean it. Condensed water, staphylococcus.
Yes, Kamal sir.
Yes, sir. So I think it was an excellent demonstration. You take this thing. Our
Rahul has taken a beautiful class, sir. Really, I am very happy. Elaborated,
excellent,
very good class.
And the second day when he came in, he went through the recap of the previous class also. So that was very
excellent,
complete,
excellent, really good.
Very complete class, sir. And so actually, I'm sure our postgraduate will have a real stimulus to take a probe and put it on the baby and see it. And unless they keep doing it again and again, these things will not fall in place and will not be able to apply it confidently. So it was an excellent session, sir. It was a marathon session. I think it was a unique one. Never has this been happened in the past. And I think we'll be setting a new example to others also. And I'm sure all our postgraduate would have benefited. We started off with echocardiography and then went on to abdomen and then went on to CNS, and then now abdomen also we covered. Then we have covered lung. Lung
so
was
whole
something
body we have covered.
We have covered, and also hip. We have this is something which we have never bothered to do hip. And lung was something very, very, something unique, sir. It was new because it was so easy to do, but we were not doing it. I mean, probably ignorance is bliss. We didn't know, and then we were not doing it. So much can be learned or diagnosed with the lung ultrasound. And as Prashant sir, our Dinakar sir was saying, now this is the tool which is going to make diagnosis more quick diagnosis and early intervention. And it was an excellent class. And on behalf of the Neonatal Association of Tamil Nadu, our president, Dr. Ramachandra Mohan, our secretary, Dr. Lakshmi.
One second, sir. Dr. Ramakrishna is also there, who has done echocardiography class, and Dr. Rahul is also there.
I would like
Ramakrishna
to.
is from Salem, sir.
Salem, yes, sir, Salem. I remember, sir, he had given one talk
Sir,
in.
any doubts anybody can ask, please, can you ask, sir?
Yes, I'll ask them, sir. I hope, are there anyone with any doubts can be cleared? And I think it was a real, initially when we had asked our Dinakar sir said, I think there were almost all the lectures was supposed to be covered by Dinakar sir, and there were, I think, 2 lecture classes by Prashant sir. Then it was a very good team effort, Ramakrishnan and Rahul and Prashant. I think we had an excellent demonstration of ultrasound techniques by all of them. And
Sir,
yeah, each one had their own way
sir,
of.
sir, can we have recording of the session to watch
Yes,
later?
So that is what I want to say.
Our IT person will be sending to Kamal sir today only. Saying, is it possible to send today or tomorrow?
I will try, sir. It's around 9 GB data, so I will try to send. By tomorrow, I will send, sir.
Yeah. So they all want to keep it, and some of them are planning to keep it in the phone and check it whenever they are doing the ultrasound. The counter check, because many things are not, they don't stay in the mind for a long. So it is good to have a recorded session and then to go back to it whenever we have a doubt. Many times we do get doubts. So with this, I think from on behalf of our Neonatal Association of Tamil Nadu, President Dr. Ramachandra Mohan, our Secretary Dr. Lakshmi, and myself, and from the faculty, Dr. Vaidishwar and others in Department of Neonatology, I would like to extend my thanks and sincere.
Sir, one small request, if you don't
yes,
mind, sir.
Yes, sir.
Sir, all these things are happened because of 2 people.
Yes, sir.
2 people. Hey, C type kodama connection. Just Mr. Ganesh and Anviti, because my 30 seconds my battery will get over. Okay. Anviti and Mr. Ganesh Janwar, please give them a big applause.
Yeah,
and
sure,
C type. Okay, and because of Anviti, everything, all designs have been done.
Oh, excellent. And I mean, I should just mention this because when we initially started this invitation, I think it was done at 2 a.m. in the morning. So there's so much of work went into it, and then they got it done. I also thank the sponsors who are for the web platform. And this was an excellent web platform where everything was crystal clear, but for a few glitches that happens in all online programs. And apart from that, don't do it very well, sir. So the sincere thanks to the Neo Gurukul team and the teachers for their contribution for this ultrasound session from the Department of Neonatology and also the NNF Association of Tamil Nadu. And I think this is a trendsetter now. I think many such sessions will happen. And anyway, this is not an end. We can always contact Prashant and Dinakar sir and Prashant sir. They're very approachable. And I'm sure if either both when they come to Tamil Nadu and Chennai, I'm sure we'll be happy to have them and have a live demo in our institution, sir. We are just waiting for that day, probably in Jan or sometime when we come here, we'll know. And hope we'll meet again in some conferences in person. I hope it will start happening from January. This corona will sort of come down. So this corona, even though it has given us a lot of problems, it has given us new ways of learning and new teachers, excellent teachers with so much of dedication. I think it's God Almighty's way of making us learn things. Thank you, sir. Thank you once again, sir. Dinakar sir, Prashant sir, Rahul, and of course Dr. Ramakrishnan, who is from this side. And thank you all so much. And thanks for the postgraduates who all took time off from their busy work and then sat and learned the techniques from the doyens. So thank you so much. There's so much of material to learn and so much to teach, and it's a real eye opener for us. Thank you, sir. That was just an idea, and the Neo Gurukul team made it the dream into real happening. Thank you, sir. Thank you so much.
Thank you, Kamal sir, for the opportunity. And our effort and team supported by our Ganesh ji from GenWorks and Anviti from GenWorks, who have sat with us to design the brochure and to help us in a very big way. Very, very big thanks to them also, sir. And Ram, are you there? Yeah, and a special thanks to him also, sir. And most important thing, Kamal sir, from our heart, from entire our team, very, very thankful for the opportunity and for giving us opportunity to teach your student. Thank you, sir. Dinakar sir, would you like to say something, sir?
Yeah, we want our Dinagar sir to say something and advice to others also. What all we need to keep in mind when we start doing this more vigorously, ultrasound.
I think his mobile got switched off. Yeah, I'm not seeing his name, sir. I think his mobile would have got switched off.
Okay.
Rahul, thank you very much, Rahul. Would you like to say something, Rahul?
Yeah, Prashant. Yeah, I mean, I never thought like it will take 3-4 hours to teach them lung ultrasound. And second thing, like maybe I mean once we do workshop in person, that will be better. Maybe next year, let us see. We can go down and have a workshop in person.
Dinakar sir, I can see your name. Would you like to say something, sir?
So yes, sir. Thank you. Thanks, Dr. Prashant. Thanks, Dr. Kamal, and thanks, Dr. Dinkar. So just to give us an opportunity to do all this from the back end, it needs a big heart, and and even to acknowledge these small efforts in a big forum as this truly shows, the relationship and mutual respect that you have for the trade as well. So it's a very significant thing, sir. This is a motivation for us to do more because it's we believe that technology, as a technology company, we fundamentally believe that we have to play a very important role in educating customers about the value of technology and to support them continuously to improving clinical outcomes. It cannot be a transaction like any other trade. Healthcare is very different. It's very important that customers do buy technology from us with a huge leap of faith. And I have been in some of the, thanks to Dr. Prashant and Dr. Dinkar, I have been in a lot of these NNF programs. And I really understand, how difficult it is to even make break even, in NICU care because there is no insurance. There is a very difficult, but it's important to save lives. Most of you are doing this only because of your passion to do lives, save lives. It's just not for any other commercial reason. So we have to be very responsible about making sure you leverage the use of what you buy as costly equipment. And newborn care needs costly equipments because if you want to save a 27-week, 28-week, preemie, you obviously need that kind of technology, and you take that big effort to buy those technologies, and then irrespective of whether there's a reimbursement or not, you put it to use. So least we can do is to support you with the continued education and support. So thanks, sir, for giving this opportunity. And I sincerely wish that we all can have a get together in Chennai. I am based in Chennai, so all of us, we can invite Dr. Prashant and Dinkar as our guest. And obviously, we should meet. And my personal thanks, and I'm very grateful for this opportunity, sir.
Yeah. Sir, I would like to mention here, we had not charged any amount for the participants, nor did the teachers take any remuneration for the teaching. It was all done with goodwill, just goodwill, and this is something very unique in these days, sir. Very unique. It was all meant for the students to learn and then apply it on the babies. That was the
very,
motto.
very true, sir. Very true, absolutely.
And any comments to the postgraduates? Hello, anyone there who want to say something? Yeah.
Hello.
Yeah. Quick. We can have 5 minutes.
Dr. Naresh Prasad.
Naresh sir, you have to unmute yourself and speak. You have been muted. Kindly unmute yourself.
Am I audible?
Yes, yes, yes. Go ahead, sir.
So, is there any possibility of getting the information about abnormalities of the bony cage from ultrasound of the chest?
Can you repeat the question, sir?
Sir is asking, is it possible to identify bony abnormalities of chest by ultrasound?
What abnormality?
Are you talking about
Naresh?
fracture, sir?
No. Fracture, everything, yes. But नरेश जी, कौन सी abnormality आपको चाहिए?
Sir, unmute, sir.
In a
Unmute.
neonate, max to max, congenital adenomatoid malformation, cystic, so lobar emphysema. In that both, if the lung is enlarged in that area, you remember always, if it is severely enlarged, one cyst or anything,
Sir, I think we are unable to hear him. Naresh sir, you are muted. You are muted. We cannot hear you.
Hello.
We can hear you now. Go ahead, sir. We can hear you. Go ahead, sir.
Is there a possibility to detect by ultrasound the hypoperfusion or hyperperfusion of the lungs, or any vascular abnormalities which are present in the lung blood supply of the lungs?
Sir, vascularity can be detected, sir. There is something called as power Doppler, wherein you can put it and you can see if there is any pneumothorax, you will not see the vascularity. Flow also can be seen. We can use color Doppler. That is the latest one. The latest 2015-16 they have done a study on use of color Doppler in identifying pneumothorax and other conditions. So it can be used, sir. We can check on the perfusion and hyperperfusion, blood flow.
If that is the no further questions, can we call it a day, sir?
Yes, sir. Yes, sir. Yes, sir. Sure, sir. Thank you, sir. Thank you, sir.
So much, sir.
Dinakar, sir. Yeah. Yes, sir. Yes, sir. Yes, sir.
I think so.
Yeah.
Whatever the question was there, only neonates, the difficult thing in the lung ultrasound is congenital adenomatoid malformation or lobar emphysema or pneumothorax. Because X-ray, suppose if you will know the first X-ray, second X-ray, third X-ray got admitted, it's okay. Or previously when the baby was in uterus, they have diagnosed, it's okay. Suppose if it comes to your hospital with a respiratory distress after 3-4 days, then you are taking the X-ray, it will look like a pneumothorax. Simply you are placing the catheter, ICDT, then you are in the soup. So in the X-ray, if it is a first year, second year, third year, then it will be more difficult because he won't be knowing. Even in the X-ray, sometimes ultrasound, sometimes because lung sliding sign will be very, very, very minimal. Switch off wherever it is. So it's very minimal, very minimal. So that is the only place where we find difficult. So CT scan is really good during that time. CT scan. So ultrasound lung is not everything. Still we have a better things are there. but it is a easy, table side, less invasive, less money, more friendly, and without money, patients job friendly. Dear sir, any doubt regarding the subject other than this, sir? Anything you want to ask, sir? Over to you.
What is the limitation of USG in cases of chest